Rheumatology. Adult medicine rheumatology. SLE. Gout. Osteoporosis. RAVOA6. S7. PSA8. Sjogren 9. Wegener X scleroderma 11. PAN 12. GCA 13. PMR. Systemic lupus erythematosus, great pretender, chronic inflammatory condition, systemic, remitting, relapsing, autoimmune. Type 3 and 2 hypersensitivity reaction deficiency of C1q, C4, C2 complements demographics, 9x females, males, childbearing age, indigenous Australians, C. Diagnosis, SLE criteria 4 or more criteria, at least one clinical, and one immunocumulative, and doesn't need to happen concurrently. Clinical. Cutaneous lupus, oral or nasal ulcers, non-scarring alopecia, synovitis, greater than 2 joints, serositis, renal, neurologic, hemolytic anemia, low WBC, 4000, low platelet, 100. Immunologic. ANA, anti-DNA, anti-SM, low complement, direct Coombs test, antiphospholipid. Clinical features, affects multiple organ systems in varying degrees, constitutional, malaise, fatigue, weight loss, fibromyalgia. Musculoskeletal, intermittent arthritis, cutaneous, mostly photosensitive, acute malar rash, butterfly rash, slightly raised erythematous rash of the face, cheeks, nose. Chronic discoid lupus rash, slightly raised, scaly lesions on the scalp and face, may have scarring. Others, alopecia, oral ulcers, Raynaud's phenomenon, urticaria, lichen planus, nail folds, infarcts, nonspecific. Renal, lupus nephritis, one of the most serious manifestations. Contributes to mortality. 30 to 50% of SLE can be asymptomatic due to glomerular deposition of DNA, anti-DNA immune complexes on the GBM. Screen, urinalysis, plus, hematuria, proteinuria, casts. Confirm, renal biopsy. Hematologic, MC is anemia, plus/leukopenia, lymphopenia, thrombocytopenia. Serosa, pleural and pericardial inflammation presented as pleuritic chest pain. Liebman-Sachs endocarditis, non-bacterial varicose thrombi, mitral or aortic valve. Immunologic features, plus, ANA, screening, serological hallmark, high sensitivity, poor specificity, patterns, homogeneous, speckled. Plus, anti-DNA, highly specific, plus, anti-SM, highly specific, RF, plus, in 50% up arrow ESR/CRP, inflammatory markers complement, test for disease activity. Management, goal, to control disease activity, refer to rheumatologist, MDT. Prevention, avoid triggers, CV risk reduction, osteoporosis. Mild, pain management, initial, NSAIDs/low dose steroids. MOD, hydroxychloroquine. Severe, corticosteroids, immunosuppressive drugs, cyclophosphamide, mycophenolate, azathioprine, methotrexate. Belimumab, for MOD severe, support and counseling. Gout acute inflammatory monoarthritis risk, male, HTN, obesity, DM, dyslipidemia strongest, hyperuricemia. Pain and swelling with acute inflammation MC site, knee diagnosis synovial fluid ASPI rate, rhomboid, weekly, plus, positive birefringent. Precipitating factors, diet, trauma, surgery, alcohol excess, drugs. Clinical features, monoarthritis, MTP of great toe, ankles, knee. Polyarthritis, dip, PIP of hands nodular gout, pain, tophaceous deposits in dip. Diagnosis, synovial fluid ASPI rate, plus, negative birefringent needle-shaped, MSU crystals, WBC 2,000-60,000/UL. Serum uric acid, N/up arrow X-ray, punched out erosions, early joint swelling, soft tissue mass. Management acute attack first, NSAIDs indomethacin colchicine now then Q6-8 until pain relief or diarrhea develops. Intra-articular steroids. Drug prophylaxis, allopurinol if with frequent attacks, chronic gouty arthritis, hyperuricemia. 6 to 8 weeks after last acute attack uric acid levels after 1 month probenecid uricosuric agent. Prevention weight loss low purine diet reduction of alcohol, soft drinks. Pseudo-gout, calcium pyrophosphate deposition within the joint space may be association hemochromatosis, hyperparathyroidism, trauma. Pain and swelling with acute inflammation MC site, knee diagnosis synovial fluid ASPI rate, pain and swelling with acute inflammation MC site, knee diagnosis synovial fluid ASPI rate, rhomboid, weekly, plus, positive birefringent. Management acute attack, NSAIDs, colchicine, glucocorticoids. Prophylaxis, colchicine. Osteoporosis due to reduction of bone mass or density diagnosis, DXA, T-score, -2.5 trauma greater than 50, plus, history of fracture after minor greater than 70, no history of trauma fracture. Common sites, vertebrae, hip, distal radius management fall risk assessment and prevention bisphosphonates, alendronate postmenopausal women men 50 OAE, esophagitis. Denosumab postmenopausal women. Estrogen postmenopausal women protective of colon cancer not for long-term use AE, breast cancer, estrogen. Estrogen postmenopausal women protective of colon cancer not for long-term use AE, breast cancer, estrogen. SERM postmenopausal women history of breast cancer tamoxifen, AE uterine cancer raloxifene, MOD risk for uterine cancer. Prevention exercise, progressive resistance vitamin D plus calcium. Rheumatoid arthritis autoimmune inflammation, pannus formation, erosion of articular cartilage and bone. Risk factors female, smoker family history of RA, plus, HLA-DR4, plus, RF, anti-CCP antibody. Clinical features 3, or more, symmetrical joint involvement, MCP, PIP, dip swan neck deformity boutonniere deformity. Signs: joint swelling, wrist, MCP, PIP, warm to touch, plus, squeeze at MCP/MTP joints, limited ROM muscle wasting late, subluxation, instability. Symptoms: pain, worse on walking, nocturnal pain, relieved by activity. Morning stiffness, malaise, weakness, weight loss. Extra-articular manifestations: pleuritis, anemia of chronic disease, interstitial lung disease, splenomegaly, Sjogren's syndrome. Investigations: up arrow ESR/CRP, disease activity, anemia screening, plus, RF confirmatory, plus, anti-CCP X-ray, mouse bitten pattern, joint space narrowing, cysts, subluxation. Management: refer to rheumatologist. Non-pharmacologic, rest, literature, weight loss, joint protection, proper footwear, support, physical therapy. NSAIDs, symptomatic relief, paracetamol up to max 4g/day. MARDs, immunosuppressant, first line, methotrexate plus folic acid ripple therapy, methotrexate plus sulfasalazine plus hydroxychloroquine. Monitor FBE, LFT, visual acuity. MARDs, biologicals, cytokine INH, anti-TNFA, adalimumab, abatacept, etanercept, infliximab, rituximab. Anti-IL-1, anakinra, tocilizumab AE, inc. Risk for infection, atypical pneumonia, TB, listeriosis. Vaccination, pneumococcal for those taking DMARDs. Fatty acid supplements, for management of pain and stiffness, omega-3, up to 12g/day. Glucocorticoids adjunct to DMARDs, oral prednisolone intra-articular/4 pulse therapy. Osteoarthritis, degenerative joint disorder due to mechanical wear and tear, destroying the articular cartilage. Risk factors: age, female, obesity, trauma, joint involvement, first CMC of thumb, first MTP of big toe, dip, PIP, knees, hips, spine. Signs: hard and bony swelling, crepitus, restricted ROM joint deformity. Symptoms: symmetric joint pain, relieved by rest, 30 minutes, worse by end of the day, and on initiating movement. Morning stiffness, transient. Diagnosis: X-ray. Osteophytes, joint space narrowing, subchondral cysts, alteration in bone shape. Synovial fluid, non-inflammatory, WBC 2000. Management: simple analgesics, oral/topical paracetamol, max 4g/day. NSAIDs, COX-2 INH, intra-articular corticosteroids for acute flare, short-term relief. Exercise. Weight management. Ankylosing spondylitis MC symptom, chronic back pain. Clinical features: New York criteria, sacroiliitis, limited chest expansion, history of inflammatory back pain, limited ROM of lumbar spine. Diagnosis: modified Schober's test. Management: first line, NSAIDs, TNF-INH, if with inadequate response to exercise and NSAIDs. PSA associated with psoriasis, ski and nails, asymmetric and patch involvement, dactylitis, X-ray, pencil in A cup deformity of dip. Sjogren's syndrome. Lymphoid infiltration of exocrine glands may transform to lymphoma, diffuse B-cell lymphoma or mold lymphoma. DXT, dry eyes plus dry mouth plus arthritis. Clinical features: fatigue, sicca, dysphagia, salivary gland enlargement, xerotrachea, chronic dry cough, ink, dental caries. Diagnosis: plus, ANA, Rho, La up arrow ESR, plus, RF anemia, plus, Schirmer's tear test, CONJ dryness. Management: refer to rheumatologist. Symptomatic treatment for dryness: NSAIDs, hydroxychloroquine, steroids. Wegener granulomatosis with polyangiitis, triad of vasculitis/granuloma, URT, LRT, kidney, upper respiratory tract, saddle nose deformity, paranasal sinus pain, drainage, purulent nasal discharge. Lower respiratory tract, multiple, bilateral, nodular cavitary infiltrates. Cough, hemoptysis, dyspnea. Glomerulonephritis, proteinuria, hematuria, RBC casts, PSGN, FSGN. DXT, malaise plus URT plus LRT. Diagnosis: up arrow ESR, anemia, leukocytosis, thrombocytosis, mild hypergammaglobulinemia, IgA, plus, antiproteinase 3, ANCA. Confirmatory, tissue biopsy, necrotizing granulomatous vasculitis. Management: DMARDs, cyclophosphamide. Symptomatic treatment: glucocorticoids. Eosinophilic granulomatosis with polyangiitis, Churg-Strauss infiltration of eosinophils in small and medium-sized blood vessels and tissues. DXT, asthma plus rhinitis plus hypereosinophilia. Diagnosis: eosinophilia greater than 1000, up arrow ESR, fibrinogen, plus, ANCA, anti-MPO, biopsy. Scleroderma, systemic sclerosis. DXT, autoimmunity plus non-inflammatory vasculopathy plus collagen deposits. May have other systemic symptoms. Clinical features: diffuse scleroderma, morphia. Limited cutaneous systemic sclerosis. Diagnosis: up arrow ESR. Anemia, plus, ANA, plus, RF, anti-SCL70/anti-DNA topoisomerase anti-centromere antibody. Management: refer to rheumatologist. Cyclophosphamide for ILD. Symptomatic treatment: pain, NSAIDs, analgesic, skin emollients, avoid vasospasms, beta blockers, nifedipine. Polyarteritis nodosa, necrotizing vasculitis of small and medium-sized arteries. Associated with drug abuse, B-cell lymphoma, HBsAg, hairy cell leukemia. DXT, arthralgia plus weight loss plus fever, plus/skin lesions. Clinical features: fever, myalgia, weight loss, migratory arthralgia, polyarthritis, livedo reticularis, skin ulcers. Hypertension, glomerulosclerosis, arrhythmia, cardiac failure. Diagnosis: biopsy of symptomatic organs, arteriography, up arrow ESR. Hypergammaglobulinemia, hepatitis B and C screening. Management: refer to rheumatologist. Prednisone, cyclophosphamide, BP control. Giant cell arteritis, temporal arteritis, vasculitis of large arteries of the scalp, head, may overlap with PMR. Clinical features: headache, temporal area, scalp. Anemia, plus, ANA, plus, RF, anti-SCL70/anti-DNA topoisomerase anti-centromere antibody. Management: refer to rheumatologist. Cyclophosphamide for ILD. Symptomatic treatment: pain, NSAIDs, Analgesic skin emollients avoid vasospasms, beta blockers, nifedipine. 11. Polyarteritis nodosa necrotizing vasculitis of small and medium-sized arteries. Associated with drug abuse, fever, fatigue, weight loss, jaw claudication, visual loss/disturbance, amaurosis, fugax, blurring, diplopia, visual field defect, limb claudication. Diagnosis. Diagnosis: no blood test/non-invasive test to confirm ESR ultrasound of temporal arteries, can only be suggestive. Temporal artery biopsy, plus, inflammation. Management: refer to rheumatologist. High-dose glucocorticoids, tocilizumab. Long-term, but rare, complications include stroke, TIA, dementia. Polymyalgia rheumatica, females, males, age 50, DXT, myalgia plus painful shoulder girdle plus morning stiffness. Clinical features: symmetrical proximal muscle pain and morning stiffness. Fever, malaise, weight loss. Diagnosis: ESR. Anemia, IgG, complement normal CK, temporal artery biopsy. Management: refer to rheumatologist. Prednisolone, low dose, azathioprine, methotrexate.